Put on our recording here. So if you have not, place your name and your campus in the chat. Check your screen name and ensure that it matches the roster. Give you a minute or so to do that. Your name and your campus, check your screen name and just rename it if it is incorrect. As always, these sessions are recorded and they are viewed by the attendance administrators. Hopefully everyone is doing well. So just giving you time to place your name and campus in the chat and also to check your screen name. Okay. Everyone has their name and campus in the chat, and then you have check your screen name. All right, so let's look back. So our plan for today is at the end, of course, we're going to push most of our time at the end for our break and then our last break. And then also at the end, we will arrange groups. And then we will, and I'm working from backwards to our time now. We'll review our week 2 content and then we will review our week 1 content. And so we would do that using the chat. We'll get in small groups a couple of times. We'll share out. And so that is how we will cover the content. Just want to bring to your attention that exam 1 is on next week. Dr. Tenza has already shared her exam review link in the chat, in the announcement section, not in the chat, is in the announcement section. So at a minimum, just make sure that you're going back, looking through the classroom recordings and clicking on those exam review links to review the exam. While it is the same information, just hearing it multiple times and then just hearing it from different people, we're saying the same thing, but it may resonate a little bit differently or better. You have that stronger understanding of it. Now all of your exams always have math on it. So we place several math resources in the announcement section as well. We'll give you the questions and then the answers are in a different posting. So it gives you a little time to work through the questions and then the answers. If you would check about 3 or 4 later announcements, and then that's when the answers are there. And then we have some more answers that we'll post later on tonight. So just give you a little time to work through those without looking at the answers right then. So, math is on every exam, I think for all of your classes. So just make sure you're looking at those different math resources. Some campuses actually have a person that's live on campus that can work with you. Some campuses don't, but just to let you know that information, you can reach out to your campus deans to see if that is available on your campus. As a reminder, if you have accommodations, and this is for all of your classes, make sure you send that announcement out and that whatever that paperwork is to all of your professors each term, that 72-hour notice in the event that you are looking to get that exam proctored on campus. Then we place some information in the announcement section also so that you can refer to if you're trying to do that proctor on campus. So you can just follow that guide that we have placed there. All right, so let's go ahead. I have sent to your Canvas mail 8 or 9 slides. So what we're going to do is we're going to do like a small group, and then we're going to come back and share. And this is week 1's information. So check your Canvas mail. Check your Canvas mail. So go to your Canvas mail. And I think in the announcement, in the subject bar, it just says week 1. It doesn't have a real heading, but there's an attachment. There is a PowerPoint. I think there's 8 or 9 slides. So pull those up and you can just do some jot noting. So we're going to open the breakout room and we'll give you about, since it's about only 8 slides, we'll give you like 5 minutes to just go through and you all just discuss them and then mark down what you think the best answer is. And then we'll come back and share out whole group. Let me get the breakout room here. So accept the invitation and go to the breakout room. And then I'll set the timer for 5 minutes. But you don't have to, do any extensive documentation. Just jot note what you think, discuss, and then just decide on what the answer would be. And then we're going to share out whole group. The breakout room is open. You're going to review those 8 or 9 slides, decide what the best answer is. You're going to come back and share whole group.
And now
Uh,
they're not.
is it week two concepts to consider?
It like did you ever get to open it at all?
It's in your
Um,
mail. It's in your mail. What I just sent it to your
Mail,
mail. It's not in the announcement section.
Okay.
Yeah, it's in your
as
mail.
in the Outlook.
No, in your Canvas mail. Canvas mail.
Oh, the inbox. Oh, okay.
Mm-hmm.
Oh, yep, there it is.
Yes. It's just 8 or 9 slides. Let me
Got
toggle to the other group so they can know that it's the Canvas
okay.
mail and not that Outlook mail.
Oh, okay. I see it. Thank you.
All right, you're welcome. Let's see. Go here. Okay, so you are looking your Canvas mail. That is
Mm-hmm.
where the announcement is.
Mm-hmm.
You have it. Okay,
Yep.
8 or 9 slides. All right.
All right. Thank you.
Bring you all back in just a few
What?
minutes. All
Oh,
right.
did it download? I guess it downloaded to my computer.
You can just preview it. I mean, you don't have to download it. Just preview
Yeah.
it
I don't know
so
why
we
it
can
did
save
that,
that
but
space.
it's
Yeah.
opening. Oh well, it
Oh, no,
opened.
this is open.
Uh-huh.
Uh-oh.
Ooh. All right. So,
You all is in your Canvas mail. That's where the 8 or 9 slides are. Did you all find them?
Yeah, I found them.
Got it. Okay. And you don't have to download it. Just preview it. That way you won't use up that space on your computer. Okay.
When I go to, okay. When I go to my breakout room, I was the only one in there. I, I can't,
Are
hold
you
on, I can't,
did
hold
you
on.
just receive another announcement,
Yeah,
invitation?
yeah, for 5. Okay, go there.
Yes.
Okay, thank
Great.
you.
You're welcome.
Sheesh.
Did you all find it in your Canvas mail?
Yes.
Got it. Okay.
Yeah.
All right. I'm setting my timer now. 5 minutes. Just talk it through. We'll come back and share our whole group. Logging back in, for the whatever the third, I think it's your third time. Just say that in the chat so that everyone, the attendance administrators will have an account of that. All right. So let's see. We have 45 seconds and everybody will be back. So we're just reviewing our content from week one. Like I said, we just look at it in different ways. So let's see, how did we do? Let me share my screen here. All right, and we'll just go groups by the first few slides. We have Beeman, Swigard, and Henderson. If you would talk us through the first slide. Deanna, Kayla, and Taylor, if you would talk us through that first slide.
Sorry, pulling it back up on my phone.
Okay.
The questions. But we had A, and I'm pulling the slide back up. 1 second. I have it on my phone.
It
I
says,
can
which
pull it
best
on my
fits your
side
role
too.
as a licensed nurse? Yeah, we all picked A. The Nurse Practice Act. Um, yeah, that's literally it. The other ones didn't really necessarily like kind of like fit in with the question, so we just all went down the line and
Yeah,
did
just because that
A.
one is like just your scope of practice and everything.
Right, yeah.
It's your to-do list. It tells us what we can lawfully do
Yeah.
within that state, and it varies state to state. They're not huge changes, but it does vary state to state. But that's literally our to-do list, our lawfully to-do list. So when I mention say the word lawfully, sometimes you'll be in settings and people will ask you to do things, and they know that it's not on your to-do list. They know that it's not in your scope of practice. So it's on you to be familiar with your scope of practice in whatever state that you're licensed in, and to say, no, I cannot do that, or yes, I can. And so in the event that something comes up later on, they're going to look at the policies and procedures for that facility, that setting that you're working in, and they're going to go back to that Nurse Practice Act. Even if, someone say they had bad outcomes, um, they're trying to sue, or there's a complaint, they're going to go back to the Nurse Practice Act. Can this person, should they have lawfully been able to do whatever it is that they're saying that they did? Does the policies and procedures match? Because facilities don't ask you to do anything. They shouldn't be asking you to do anything that's not on your in your Nurse Practice Act. But every now and then things will get, through the cracks. So Nurse Practice Act, yes. And like y'all just did a test taking too. You said, well, hey, these other things, they didn't even match the question. So keep that in mind. Remember, we're talking here, but we're looking at our NCLEX, you're looking at your HESI, your exam questions. If it doesn't match, don't try to make those placeholders. That's what they're called, placeholders. If they don't make sense, there's no connection, that's not the answer choice. All right, so moving on, we have Brown and Lewis, Adina and Amanda. Talk us through the next slide.
We chose C, the client, because that would be your primary source of information as long as they're coherent and they're able to understand.
Yeah.
So, and then the others would be like secondary and, so forth, because subjective, objective, basically what they give and what you observe for yourself. And the family members, they're not always accurate because they're not always around the client sometimes.
Right.
Exactly. You would think, oh, they're a family member. Sometimes they're just not
They're
accurate.
not
They just
around,
they have not a clue is what's going on with mom or dad or brother or sister. So yes,
even with their health, because the
exactly.
family members will know whatever the patient or their family member tells them, but
Right.
do they tell them everything?
Yeah.
Probably not. So yes,
Okay.
the client, they know their body and themselves better than anyone else, right? So unless
Hmm.
there are extenuating circumstances and that person cannot respond, like if we go in and there's no pulse, no respiration, they cannot respond.
Yeah.
But that primary source is going to be the client. Got it. Good, good, good. Let's see.
I have a question about that.
Mm-hmm.
Okay, so you said it was the client.
Mm-hmm.
Clients aren't always truthful. So I figured that it was the objective findings because we can see and fix what we can see. And if we don't see it, we can have labs
No,
or do assessments and figure that out.
Okay.
yeah, but still the
So
client will always be right because they still know what they're doing. You're not talking about a dementia client. You're talking about somebody that's probably coherent. Yes, they might lie, but you can make your observation, but you still have to listen to what they have to say because it's their
so
word.
even if they are not telling the truth, you still note that, because later on, one of the care plans would be that this person might not, you're going to verify that information from the client anyways, whether or not they're coherent or if they do have dementia. You still want to capture what they are saying. But a care plan might be that this person does not give factual information. This person is confused and they give mixed up information. You still want to capture what they are saying. Because, say, for instance, the person is coherent, but they are giving you wrong information. So, in the event that there's a complaint that comes up against the nurse that's taking care of that client, if they have it noted that and documented that this person tells things that are not true when they do their complaint, they're going to take that in consideration. Ma'am or sir, we do have a history. We have it documented. Nurses come in, they gather information. These are the things that you have told them. When we verify this information, we verified it with you or whomever we verified it with, these things did not match. So you still want to capture whatever that client is saying, whether or not it's factual, incorrect, half correct, or whatever it is. You still want to. And then what was the other person? You said objective information. So remember, for objective, a lot of times we start our conversation out with specific questions. But if that client just starts talking, they're going to give you more information than you really want to document. They're just going to give you everything. But when we're going in specifically asking questions, we kind of limit them. So, but if you just let the client just have free range, they'll tell you everything. All right. So we have Jordan and Sarah. If you would talk us through slide number 3.
Number 3. So Maslow's hierarchy of needs, the highest level of need, we said C, self-actualization. Is that we weren't clear on if it was like highest, meaning like highest priority, like, or if it was highest, like literally the highest level on the pyramid.
You got it. And that is good thinking, because highest would be the bottom, right? But for this question, they were asking you the order, which one is the highest in the pyramid. But yes, but the highest really, if we're talking about whether or not this client is going to survive or not, we're talking about that bottom layer, right? Which is the food, water, and stuff like that. But yes, so for that question, they were just asking about that. Great. Thinking it through. That's good. So we have Andrea and Kalia. Slide number 4.
I think it's C.
Okay. Yes. Florence
I
Nightingale.
agree.
You agree? Great.
Yeah,
Florence
sorry.
Nightingale. Go ahead. So she did implement medical asepsis by improving sanitation. Who would have thought? Just keeping things clean, washing hands, wiping down surfaces. And essentially that's what she was framed for. That's how it all started, rather. Hey, this stuff needs to be clean. If we're going to be touching people and people are going to be touching us and they're going to be laying on surfaces, we need to have these things clean, providing clean linens. And then the other piece of it she brought in were those nutritious meals. That's all a part of having that person, being in their best health. But just a matter of just keeping things, is almost with our ABCs, keeping things clean as we can get them. That's sanitation. Good. All right. And then let's see here. Our last group would have been Brittany, Curry, and Tiffany. Slide number 5.
For number 5, we chose B.
Okay, that's correct. We agree. So, and then as time has still evolved, the role, the practical nurse has been recognized as just as important as anyone else on that healthcare team. I know this goes back to after World War II, but even now, the United States, Department of Education, they here in the last maybe 10 or 13 years, maybe a little bit longer than that. It says that, hey, we're just as important as anyone else on the healthcare team. All right, so that was just to get us to thinking and listening to others. So we're going to finish up with the week 1 review here. I'm going to share my screen. I'm going to move forward. And then you can, on your paper, you can just jot note. You don't have to actually answer right off. Let me see. Is my screen sharing? Let me stop. Because I don't think it's shared. Okay. Move this out of the way here. So, how did COVID-19 pandemic impact the demand of nurses? So, before COVID-19, there was already a shortage. There's been a shortage ever since it's been a shortage. So, something like a pandemic further increase the demand for nurses, especially in long-term care facilities and in the community settings. It was just, if you just think back, that we had makeup, at the health departments, at doctors' offices. They had to drive up, injection clinics, to just drive up, and the doctors and nurses would come out and assess you. It further increased that demand, especially in those community settings and long-term care, because that's considered people's homes, and so that is out in the community as well. That public health, it increased the demand for nursing and the healthcare team in public health. So what is that role of nursing process compared to the RN? So when you select your answers, make sure, go back to the root of the question. Is the question asking you to delegate to unlicensed personnel? Is it asking you something that you can do independently? We can go in as LPNs, we can go in and gather that data, and we can implement. We can administer medications. We can do tube feedings. We can administer medications of various routes and everything. So make sure that you do understand what is asking you in that question, because LPNs collaborate with the RN in all steps except that nursing diagnosis. That's the RN's responsibility. So just make sure
But
when
the
you're
nurses didn't make diagnosis. I thought it was only the doctors that did that. I was a
that's
little bit
medical
confused with it.
diagnosis. Medical diagnosis are doctors. That
Okay.
NANDA is nursing diagnosis. So the
Okay.
RN does that part. Good question. Well, good comment. Okay, so the LP, if a client's subjective comments do not match your objective data, because sometimes the client is telling you what they know, or they might be telling you things that are not true. But most of the time, they go ahead and tell you the things that are true, but then it doesn't match your observation. For example, client, they'll actually be in pain. You'll see the facial grimacing. You will actually hear the moaning. The moaning. You may even see the grimace, the guarding. But then they'll tell you, "Oh, I'm not in any pain." So then that lets you know to further ask those detailed questions. So we should report both subjective and objective findings, and then you're gonna, of course, collaborate with the RN to further evaluate and see, well, hey, was it miscommunication? Did they really not understand what I was saying? Were they ashamed? Was that therapeutic relationship not established, and we're not safe, for them to tell, they feel that we're not safe to tell the truth? What is it? But the LPN and the RN will collaborate and then determine whether or not what's the next steps. Because there are times when, I know pain is a big one. Sometimes people, they just don't want to tell you that they're hurting because they feel like they're bothering you. So they'll be in pain, but everything that you are observing, like, wait a minute, you're moaning, crying, grimacing, something's going on. So what determines the legal scope of practice for the LP in the nursing process? The LPN must know and practice within their scope, which you all told us that defined by that Nurse Practice Act of their state or country. So many of you all probably will be doing the travel nursing. You may have more than one license. Just make sure that you're abiding by what's in that, whatever is on your to-do list, which is the Nurse Practice Act for that state. So which characteristics is necessary for a well-written client outcome in the nursing care plan? Remember, we need things as specific as we can. And what that means is we need things that are measurable, realistic. You have that care plan book. If you look at I think it's small in italicized, it has different settings. So some of those interventions, if you're in an acute care setting versus if you're in a long-term care setting, you might not want to choose that intervention for that client. That intervention might not be applicable for that setting. So that's what we were talking about, being realistic, measurable. And for example, if we're saying we are trying to assess whether or not a medication was effective for a fever or blood pressure, when do we come back and recheck that blood pressure? When do we come back and recheck that fever, that temperature, to see if it really did any good? So we want to be as specific as we can. Every 2 hours, every 4 hours, on second and third shift, just be as specific as you can with that. Why is it important for the LPNs to improve their critical thinking skills in today's healthcare environment? For one, things are just rapidly changing. We do have all these improvements. That's why people are living longer, because it's rare that someone don't want to take care of themselves. It is them gaining an understanding, having access to whatever the solution is. For example, if the person needs to be managed by you know, we'll say a specialist of any kind, then how do I get to that specialist? You know, if transportation is an issue for me. So it's not that I don't want to get to the specialist. I can't get there because I might not have a vehicle or it might not have public transportation. You know, my insurance might not pay for that transfer. I might not have money to pay for someone to take me there. But because there's so many changes and updates, the latest information, you know, we just have to be Johnny on. We have to improve our critical thinking, and that's why I said on week one, we're life learners. We're learning the latest, greatest because things are just changing rapidly, and hopefully for the better. Hopefully for the better. So, what's going to guide our critical thinking in that nursing practice? It is guided by our professional standards and then the evidence-based practice. What's the latest information with it? Don't go back that latest, that 5 years. You might actually be selected or have the opportunity to work on your policies and procedure committee in whichever setting that you decide to work on. And what they do is every so often, they look at the Nurse Practice Act, they look at the latest evidence information, and they update their policies. And so that is needed because we need to be doing whatever the latest and greatest things are for our patients. So, which behaviors best demonstrates critical thinking in nursing practice? A nurse who questions the reliability of the sources and keep an open mind in demonstrating critical thinking. Because, you know, we can do things, you know, we're not changing our policy and procedure, but things can be done a little differently. You know, for example, with the checking a temperature, you know, in the event that we go in and we have this, you know, the little scan, the tympanic, we might even have the one that goes up on the axillary one. But then in the med room, they may still have the old one where you have to actually shake it down, and we're getting some strange numbers. It might be that, you know, we need to check that temperature in a different route. We have to go pull that one out, or we might have to check it rectally. So all of those, that's a different way of having an open mind. For example, blood pressure. We got that automatic cuff. We're getting some strange numbers. It could be low, extremely low or high. Pull out the manual cuff, pump it up, you know, do your 2-step. And so we're not changing the policy and procedure. We're still checking the blood pressure and we're verifying it, but we're keeping an open mind and we're critically thinking because, you know, we want to verify the information that we're getting because once we use SBAR to call and report or to communicate to that healthcare provider about that change in your client, then the next step is going to be some action items. So we do want to make sure that the information that we're giving is reliable, is correct, because more than likely we're going to have some next steps for our patient. Whether or not it's administering medication, it might be discharging them to the hospital. You never know what it'll be. So self-confidence is developed through successful experiences and enhances critical thinking. So hopefully you all have been enjoying your clinical sites, your different rotations, and you've been embracing, you know, the different patients that you've been working with, and also in the different settings. Hopefully you all have gotten to rotate through some different settings, so you can just see the difference in, you know, your home health. Someone's in their home versus someone's at the long-term care facility, whether or not someone's prepping for surgery and you're down in the OR. The nurse uses both theoretical knowledge and previous experience to notice relevant cues and interpret patient needs. So you're going to take all that theory information that you've been reading from your required readings. You're going to take your clinical experiences, even your simulation experiences. And you're going to be putting all that together. Are there any connections? Even if you have to go back, you all, to that body system. Okay, wait a minute. Which body system does this mostly affect? Respiratory. Well, what is the respiratory system supposed to do for me? What are the organs of the respiratory system? Even if you have to go all the way back to that to kind of help you make the connections about what's your next steps. Because remember, in a few months, you're going to be that leader of that team. They're going to be coming to you. Hey, patient in room 201, they're not responding. Patient in room 201, I got their blood pressure and here are the results. So what is going to be our next steps? So pattern recognition is important in developing clinical judgment. It allows us to quickly identify clusters of symptoms, you know, going back to you all saying, you know, that subjective information. This patient usually readily responds. And they have said in the past that they have, whatever that is. And now we notice this person, they're responding, but they're a little slow about responding. And they have told us, whatever they've told us, but it's different. So we can quickly identify, wait a minute, this is a change for this patient. Even if they do have dementia, especially if they don't have dementia and they're usually alert or any times four, you can quickly recognize there's a change. But even with clients that have the varying degrees of dementia, they're not giving you correct information all the time, you can still tell whether or not there's a difference in their status. Okay, so why is clinical judgment particularly important in acute care nursing environments? So someone read through it in the chat, put A, B, C, or D. I'll give you a minute to just read through this and think about it. Let me put a minute on the screen here. Why is clinical judgment particularly important in the acute care setting? I'm trying to get to my little timer here. A minute will be up by the time I get to it. Just respond with A, B, C, or D. Uh-oh. I went backwards. Okay. Clinical judgment is only necessary for administrative tasks. Clinical judgment is used only when following physician's orders. It's not required in acute care settings. Is essential for prioritizing care and responding to rapidly changing patients' conditions. And those conditions can change so quick. Seems like you could have just left out of that room talking to that client or peeping in, checking on them. And their status can change at a moment's notice. So yes, it is essential in prioritizing care and responding rapidly to changes in patient conditions. Again, when that, like we just were saying about the client that has dementia or the client that is alert or any times four, you will be able to identify quickly, something different about this client. Because usually when I ask a question, who they are, what's the purpose, they talk about, whatever it is. Okay, our little minute is up. So either way, you want to capture what they are saying. Are there any questions about week one's information? All right, so let me just do some what ifs here. Let's see. So if we have a client that the UAP comes and tell us they are not responding like they normally respond, what would we do? Would we go ahead and notify the physician? Would we go ahead and document, or would we go down and assess the client?
You would go assess the client.
Okay. All right. We would go and assess the client. So is assessing a method of using your critical thinking? When we go in and assess that client, we check their vital signs. If we're checking the Holman sign, if we're checking pulses, is that?
Yes, because as long as you know their baseline, you can do your assessment and if they're declining or, before you even notify the physician.
So assessing is considered critical thinking. What about if we're looking at the pharmacy, the lab has called and say, hey, patient in room 201, I'm reporting the lab results. Their potassium, their sodium, their white blood cell count is. Or if we're looking at those labs, they just printed up on the printer and we're looking at those and we're going down that list. We're saying, this is high. This is low. This is normal. Oh, this is high. So this must mean, for example, this sodium or potassium is high. This might mean that this client has, or this person's H&H is low. This in that thought process. What
You
is
can
that?
think about it. That's like a critical thinking. You can think about it. And when you call a physician, you can give them the lab results and you can tell them what you think as well, because sometimes they like to know what you think, just to know if you're on top of your game as well. So you can say, hey, her potassium is low. Maybe you need to prescribe her some potassium or something.
Okay. And so that thought process of looking at lab values, and when you go down and you say this is high or low or this is normal, and your thought process refer back to your required readings. Remember, you in med surgeon, you reviewed the cardiovascular system, you reviewed the respiratory system, and all these different disease processes. That is critical thinking. What about when you go in and you are assessing the client? You're in that talking and you say, hey, are you in pain? When you go in and say, well, the discharge instructions have been given. I've come in to reinforce these instructions. Did you have any questions? Either of those scenarios, is that critical thinking or not?
It is because it's kind of thinking ahead. It's kind of like preparing ahead. So like you go into the room and you want to know the answer of the questions that they have. So like you prepare yourself for what's coming next. I think that's kind of like a way of looking at it.
It is critical thinking. We are assessing. Is it someone else? Go ahead. In one instance, we were directly, specifically asking about their pain because we might have to administer pain medication again. The other instance, we were reinforcing client education. We need to know, hey, if we need to, call the RN back in, or we may need to call the dietitian back in because they didn't understand or they just needed more information regarding whatever the topic was. And so, yes, it is. So nurses, we of course we're going to be caring for multiple clients. I know in your clinicals you may have had 2, 3 clients, but you saw how those nurses, in the hospital settings they may have had 3 or 5. In the long-term care facilities they may have had 15, 18. So you're going to be caring for multiple clients with a variety of health issues. Those clients more than likely are going to have more than one thing. So it is important that we learn as much information as we can, seek out assistance from the team lead, and be up on our game so that we can critically think. And as we're answering questions for your NCLEX and your exams and your HESIs, be thinking about it critically. Like what is there a connection? So critical thinking. It is critical thinking in the nursing process. Those are those 2 methods that will help you. And I don't want to say solve a problem with it because the patients are not problems, but essentially, if you have the person in pain or if you have the person that's short of breath, the shortness of breath and that pain is the problem. But that critical thinking and that nursing process keeps you aligned, structured, so that you hopefully don't forget anything. And so they're different thinking methods, but they both help you to solve the patient's, I don't like to say problem, but it really does help you to solve that patient's problems or issue or whatever it is that they had going on, whether it be pain or a high blood pressure or low glucose. So what if our client refuses a treatment? It could be anything from taking pain medications, blood products, if they don't want that Foley catheter, if they don't want that feeding. What do we do? Do we make the client take the whatever it is, the intervention?
No, it's their choice.
Yeah, you can't force them. You can only tell them the benefits of it and what's going to happen if they don't take it. And they can still choose, but they have the right to choose a yes or no if they want to care.
As long as we get, like, you're right, making sure they have enough information so that they can make that informed decision. They have a right to refuse. That client has a right to refuse. Okay. So what helps us to decide, to determine? I know we talked about Maslow's hierarchy of needs, but what helps us to determine priority on that triangle? Is it the self-actualization, or is it the airway, breathing, security, food, and those things?
Airway breathing first, and then food because you have to see if they can actually eat, swallow, and then
Okay.
everything else afterwards.
Okay. So, and sometimes we don't think of it as like the example that I gave about looking at the lab values. They're calling, we on the phone with lab, they're calling out these numbers. X-ray. They're calling out the impression or the final evaluation, or we're actually looking at the report. Sometimes we don't really think that that's critical thinking, but we're all the time interpreting information. We're trying to see if there's any connections. We are, even the patient data, as they're talking to us, we're interpreting that information and we're comparing it. And you may not have thought of it like that, but you're like, is this what I learned? Is this what I read? We're comparing that information to see if it's relevant, to see if it matches. And then because we're gonna know, the next thing is, do we need to act upon this? We need to verify it because it's abnormal. And then is this something that we should move forward with contacting that healthcare provider? So I will say the nurse, we begin to assemble or put together all that information that we're given, whether or not it's verbal or if we're reading a report. And so to speak, we're making sense of it and seeing if there are any connections, identifying are there issues. Is this normal or abnormal? Looking at this client, is this client stable or is this client unstable? And then that helps us to prioritize that interpreting, and so that we can identify what our next steps are. But yes, clients do have the right to refuse, but we do want to make sure that they have, an understanding. But and for one, we do have interpreters, because if I don't understand what you're saying, whether or not it's the wrong, is in the not in my first language, or if it's not on the level that I understand. So remember, when you're talking to your patients, you want to talk in layman's terms, just make it plain, is just therefore they can make an informed decision and ask, well, hey, is it anything that I've said that doesn't make any sense, or you need someone else, or you need me to go back over it? And so therefore they can make that informed decision. Now, no matter how, sometimes there are instances that client, they understand, hey, this is the intervention that you're trying to implement would be the better thing. Sometimes they just don't want to. They don't want that pain medication. And it could be for whatever reason. They think they're taking too much pain medication. They don't like the way it makes them feel. It could be cultural thing. It doesn't matter. They still have that right to refuse. So when we look at, let's see, we check the blood pressure, boom, boom, we see the dial, and we get the reading from that blood pressure. Is that objective or subjective information?
Objective.
Okay. And so if the client states, hey, I check my blood pressure at home, I have a little my self-monitoring, I use the wrist one. Is that subjective or objective information?
Subjective.
Okay. All right. So if we do a dressing change and we measure the wound, we get our 3 measurements, and we also know whether or not it has an odor or not. Is that subjective or objective?
Objective.
Okay. What if the client says, hey, they've already told me when I go home, when I do my dressing changes, I need to place the contents that's removed from the dressing in a bag, tie it up, and then place that in another bag to be disposed of. Is that subjective or objective information?
Objective.
Subjective,
That
because
would
the
be
person,
subjective, yeah,
the
because
client is,
they're
stating.
telling you what they heard, yeah.
Exactly. So just think about, subject is that person, whether it's a patient. Don't get tripped up on the setting that they're in. The person is telling you, that information. I have hypertension. I have diabetes. My pain is a 7. I am in pain. These are things that the patient has stated. So another piece of critical thinking is validating. We've already said verifying that the data information is correct. We brought that up early on. So verifying, interpreting, using, even if we have to go back to our body systems, the organs, and all of that information is going to be really critical in us providing that best care for our clients. All right, I think that's it for right now. Let's see. Let's do some prioritization in care. Who are we going to take care of first? So remember, we're going to take care of all of our patients. So don't get tripped up on that you're not going to take care of the other patients. HESIs, NCLEX, they're big about prioritization. Now, you all just told me about the triangle, Maslow's hierarchy of needs. You're talking about airway, breathing, circulation. So we have a patient that, let's see what the patient is doing. We have a patient that is having trouble completing sentences and they're using their accessory muscles. We have a patient that has asthma and we administered their inhaler and they are playing the game of volleyball. We also have a patient that is post-op 10 hours and they are saying that they are in pain. Which one of those patients are we going to take care of first or should be
Stop.
The first one, the one with the using accessory muscles and they can't speak because it's airway, ABCs.
Got
Oh
it.
yeah, you're right.
So that's right. So go. So when you're answering those questions, when you have that dry erase board, jot down ABC or draw your triangle so that when you get those priority questions, it'll go back to, okay, wait a minute. Okay, ABC, then Maslow's hierarchy of needs. So yes, remember ABC trumps it every time. It might not outright say this person's having shortness of breath, but we do know that sometimes there are some things that we can observe that client doing. If I'm talking and, I have to stop every so often and I'm using the accessory muscles, I am having trouble breathing. Now, we more than likely will go ahead and count the respirations. We'll get the O2 set and all of that. But more than likely, that person's having a problem with gas exchange. And so it is rare. Remember, it is rare that your questions are going to specifically say, hey, define what a person that's deficient in gas exchange means. Remember, you're going to have to know what that is, the signs and symptoms, the different definition of it is, some examples, and apply it and be able to pick it out. Because remember, these are next gen questions. You have to know and have an understanding of what a concept is to be able to apply it to the situation and pull it out. Now, you all just told me airway, breathing, and circulation, and that is correct. Then that bottom layer, and then go up. So just go back to that. All right, let's go ahead and look at weeks 2 information. We're almost down to our first break. So what we have left is week 2 information, then we'll recap everything, and then we'll get in groups for your group project. So when we do like the little mix of small groups, you all don't get that confused with your group 10 project. So you'll have time for that as well. And then what's the last thing? I think that's what's left on our agenda. So group 10 project, week 2 information, and then just do a recap. Okay. So let me pull up our information here for week 2. So don't forget those quizzes. You have that one time to sit and take those quizzes, and they are 50 questions. So make sure that you have enough time. And I can't say make sure you're in a good place for connectivity because I don't know what's going on with those bandwidths. It just depends on it. It does what it wants to do. But for sure, make sure you have enough time to do those. It's 50 questions because you only have that one chance at the quiz. But for the lessons, you can redo those. So just keep that in mind.
Did you get our email for the Columbus Westerville campus for being proctored?
Who did it come from? Not that I saw.
Kayla.
Did you send it to the Outlook and did you include your campus dean and Dean Brown in it? I don't remember seeing that. Not to say it's not there. Not to say it's not there, but I can look for it. I'll make a note.
I sent it in the email on yesterday. And I just tagged like the three of Curry, myself, and another student from a different class. I put you, that student's teacher in it, and then the teacher that said that was going to be proctoring us.
Okay. Each student needs to reply, and you need to include whoever that proctor is going to be and Dean Brown in there. So did you say your campus dean? So let me tell you who needs to be in the email. Each student And each student can send their own email, but since you started up like that, that's fine. But each student needs to reply to say, hey, this is what I want to do, because we don't want any confusion about, well, hey, I really didn't want to do that. So each student needs to reply. And also we might need to start a new one that includes that what therefore you have one with everybody in there. Dean Brown, Darlene Brown, and then the campus dean. And usually the person that's proctoring is not going to be the campus dean or whoever's going to proctor it. And then each student can reply to say, hey, yes, this is what I want to do. I want to take my exam on this day and time. I am agreeing to this, or I disagree with that. Because we have had it, but at first it was a good thing for example, me, but then after time went along, I didn't want to do it, but then we had it set up for them to proctor. So we need each person's response, and then all of those persons need to be included in there, because that proctor has to be approved by that campus dean. And they're the ones that say, hey, yeah, this is okay. And I will look for that email, Kayla.
Okay.
And then, so just know that that's how it should be set up, you all. Therefore, everybody knows, and we're all in the correct place. All right, so let's transition here to week 2. Just a few. So that's good. You all are getting it out early on, that way we can clarify and get everything rolling. And no, I don't know if this is in that person, that proctor, whoever that approved proctor is, but they'll come back and usually will say, well, hey, yes, I have approved this, and they'll list a date and time. Now, usually this day and time, some proctors are okay, depends on what else they have going on campus. In that email, they will say, hey, I need to move it to this day and time, whatever it is, that is good for that proctor and then you all. And that way, because like I say, some campuses have things going on, and they will know on campus where you all can be. And I'm saying that to say, in the event that they need to move it up an hour or back an hour, they will include that in that email. And it's whatever, that is agreeable by that proctor and that campus dean. They're the ones that govern that. Okay. Well, my little clock is saying it's time for us to stop and take our first 5-minute break. So remember that these sessions are still recorded, you all. So just turn your cameras off, and we'll see you back at 6:36. You can turn your cameras off. Make sure you mute it. All right. All right, so let me pull up our week 2 information here. Oh, okay, here it is right here. My little stuff. I had downloaded it. Try to download it again. Okay, here it is. It's opening up. So we're going to look at legal concepts, ethics, and legal. Okay, let's open up this one first. All right, let me share my screen here. And so knowing what these principles are and understanding what ethics is and legal is in reference to healthcare, that will help you narrow down and select the best choice. Let's see, slideshow from current slide. So ethics is just that system of standards, and it guides us to say, "Ooh, this is the right thing to do." And when we are experiencing the wrong thing happening, we can quickly identify also, hey, this shouldn't be happening, or this should not go this way. So the ethics is that system of standards or moral principles that directs our actions as being right or wrong. It guides us, and then also, like I said, we are able to quickly identify when something is being done wrong. We talked about the Nurse Practice Act. We can lawfully do these things, but there are sometimes. So hopefully you all have embraced your settings, all the various settings that you have rotated through for clinical. And you got a good understanding, a pretty good understanding about what goes on in those settings. So, after you get your license, you start deciding, which setting you want to work in. And I say that because sometimes our personal ethics, things that we think are right or wrong, they bump heads with what our professional ethics is. So remember, the Nurse State Practice Act says, hey, we as a nurse can lawfully do these things in whatever state that you're in whatever city. But personally, you may say, I don't want to do that. So for example, it could be a procedure that a facility provides. In this setting, it's a facility that provides toenail removal, and it also provides a person to come in, and if they need IV hydration, they can come and get those things done. But personally, you may think, I don't want to be involved with those toenail removals. But then you signed up to work there, and it's your day to work on the side of the clinic that does toenail removals. But personally, you don't want to be involved with that. So of course, but lawfully you can do those, whatever those steps are, those tasks. You can implement whatever that because their policies and procedure is lining up with the state nurse practice act. But because how I personally feel about it, guiding right or wrong, I don't want to do it. And so that's a conversation that you so be listening when you go to interview at these places. Make sure that you're reading and seeing what's all listed on your responsibility list. You know, if it says that you're going to be managing a team of 40 people, 30 people, and you're going to be required to do 1, 2, 3, make sure that you're looking at that and then asking those questions. Well, in the event that my personal ethics, collides, or, I don't want to perform whatever this is, what would be my actions? So that's a question you can ask in an interview. Because there are times, some settings you like, don't want to do this. I don't have any parts of that. And not that it's anything bad. It's just that personally, you just don't want to be involved with it. So individual autonomy means self-rule. Individuals have the capacity to think and based on these thoughts to make decisions freely, whether to or whether not to. They have that freedom to choose. Individual rights means the ability to assert one's rights. To the extent to which a client can assert his or her own rights is restricted. Their rights cannot restrict the rights of others. So, for example, the client's right to refuse treatment can be at odds with the healthcare professional's perceived duty to always act in a way that will benefit the client. So you're going in trying to administer that antihypertensive medication. You're going in trying to do that dressing change, and that client is preventing you from providing that best care because lawfully you can administer this medication. Lawfully you can do this dressing change. And so that's a time when their rights are kind of inflicted on your rights as that healthcare provider. And so, there's procedures. The person does have the right to refuse, but we want to make sure things are well documented and making sure that that client consents to care, because we don't want to just give it to them or make them do it. We want, and sometimes just providing that alternative where, hey, if you don't take this antihypertensive, because sometimes people don't take medication because of what way it makes them feel or whatever their understanding is, and we offer them an alternative, well, whatever that alternative is, that will help them to be able to make an informed decision. But at the end of the day, they have the right to do or not to do. So ethical responsibilities of nurses, client, we're advocating for that client, accountable, even colleague reporting. And we don't have to know all the details, but we think a client is impaired, a colleague is impaired. The boards of nursing, they have these programs that they don't want to take nurse's license. They have it out. They have these programs in place. If a nurse is impaired, they have, and they rather that nurse come to them to seek out assistance and go through their program so they can get assistance so that they don't harm themselves or a client. And so sometimes, in the event you want to, and I'm sure you probably done this on, that you have reviewed this in which class, of where, they're, we don't know because a person always wants to administer your pain medications, or, someone, go ahead and wants your password, that they're really up to no good. But those are just some signs that, you want to be careful with. But in the event that, think someone's impaired, we do want to encourage them to report it. And also you may have to report that yourself. So these principles, they guide us, making sure that we're fair to all, that we're being true, that, in the event that we say, hey, we're going to come back, we so quick, it just rolls off. I'll be back. I'll bring your water pitcher back out, and it may seem small, but remember, we're trying to establish those therapeutic relationships. And what happens is, if we say that we're going to come back in an hour, even if we can't go back, we need to send someone in or ask someone to go in and say, hey, let them know I'm tied up. I can't come back right then. I will be back, soon or before the shift's end. Because otherwise it's going to look like we're being dishonest with our patients. And then that therapeutic relationship is going to be backed up on. So we just talked about they have the free to choose. We want to make sure that we do no harm to our clients. We want to make sure we take the time to review those orders. if a facility has in their policies and procedures that we scan, the medication, but prior to giving it, and if we're scanning this medicine and the computer is not reading or connecting or identifying what we're scanning is correct, then do we just go on in and give this medication? I know this is the right medication, but this computer, it must be acting up. No, it might be that whatever's in that barcode, it may be mislabeled, because people do get medicines that what's in the container doesn't match what's on the label and vice versa. So the different practices that facilities have in place, it is so that we will not cause harm to our clients. So in the event that something's not flowing as it should, as the example I gave, a lot of facilities, you scan those meds. And if that computer is not picking it up, we need to pause, look at the order, look at the label, because if we just go ahead and give it and we cause harm to that client, then we're liable. And it's like, well, pharmacy packaged it, but we actually administered it. So we have something called beneficent paternalism. And it's like the opposite of autonomy. We want to promote our client, make a decision. We're going to support you in that decision. But what beneficent paternalism does, here's an example. First of all, it's only used for emergency situations. You usually don't see this every day. It's used for emergency situations. Usually there's some type of situation. Here they have where the healthcare provider is saying that whatever the intervention is, the treatment option is best for the client or even the client's parental guardians, parents or either guardian has refused. Beneficent paternalism is where that healthcare provider will petition the courts so that the case is heard. Like I said, you don't hear this often. It's only used in emergency situations. Is considered a disrespectful attitude if you think about it, because we want to support the client's autonomy. They have the right to refuse. They have the right to choose. And so it's sort of like the physician is saying, I know what's best for you. And so they petition to the court so that the courts can hear, because at the end of the day, they really want what's best for that client. But sometimes we struggle with, this client has the right to choose. Even if, for example, if a client, on another note, a client has a DNR order, do not resuscitate, not intubate, don't do any of those things. And we're like, oh my goodness, if we could just give them some air, ambu, if we could just, do chest compression, I know we can, but this client has these orders in place. And so that's going against what the client has wished, or what they have decided that they want, the type of care that they want. So, because remember, those documents are legal, they're legal binding documents. We talked about the Nurse Practice Act. The State Nurse Practice Act defines nursing practice and established standards for nurses in your state. So ignorance of your state's Nurse Practice Act is never defense. So what that means is, well, I didn't know. So once you get your license, the boards of nurses, they usually give you your own personal copy, whether or not it's electronic. Some, I don't think they do much of the not the brick and mortar, but the printed ones, but you can print it. But they give you your own personal copy of what that Nurse Practice Act says. And then usually the state starts you off with a couple of webinars where they're actually going over the standards. It's just so that you can, know, well, hey, I can lawfully do, so you can speak up and say, hey, I can't do that. That's not in my scope of practice, or yes, I can. Because a defense is never, well, I didn't know I couldn't do that. Because it's going to be on you. So what's in this Nurse Practice Act? It has the general procedures, license process, elements of unprofessional conduct, information related to reasons for a suspended or revoked license, the impaired professional program. That's that program where I mentioned earlier about the colleague reporting. They have programs and resources in place for impaired nurses. And it tells us our responsibilities. Those responsibilities are those things that we can do lawfully. Okay, that's fine. That we can do lawfully. Okay, in the general functions of the licensed nurse, it defines the nursing specific definition of nursing, specific definitions for the practical nurse, standards of nursing conduct, organization approval and administration of nursing programs, continuing education. So you sign up to be a life learner because usually most boards of nursing require you to learn, have so much credit of continuing education. Now it's up to you to decide what education that you want moving forward to keep your license renewed. Because remember, license is not you get them one time and you just got them forever. You know, there's some requirements, some things that you'll have to do in order to keep them active. And you have to meet deadlines. If you don't meet deadlines, for example, I want to say it's December 31st. In most states, if you don't have everything done by that date, when January 1 rolls around, you cannot be employed and go in those facilities and acting as though you still have license. So, but you'll get all of that information once you get your license from the Board of Nursing. So, Board of Nursing functions. They come in and approve the schools of nursing. They determine how much time we sit in this class versus another class, how many clinical hours you need. They come in and look at all of that. And they also maintain an inactive status list. I know when the pandemic occurred, they were asking people to renew. And then of course, they had to go back and do whatever that is, the steps to renew, getting the continuing education. A lot of nurses were retired. They was like, no, it's been so long that they had been out. But there's still a list of inactive people. There's a bunch of nurses out there, like I said, they have retired and they just have not maintained their license. They have these programs for impaired nurses, like I just said, suspending and revoking license and dealing with the appeals process. So you want to make sure that you're documenting everything because that lessens the chance of someone trying to say that something happened the way that it didn't happen. So we want to take the time to make sure we're documenting anything because what happens is usually not right then. It's later on when you taking care of that another number of patients when something to come up. And what do you have to rely on? Yes, they'll ask you questions, but they're going to go back to what was documented to verify, what actually happened. So just making sure that we document everything. I know you think like, how am I going to do all that with 18 patients, with 5 patients? You'll have time. You just have to manage your time and then just keep it on the to-do list. I have got to, no matter what, I got to get all this stuff documented. Whether or not the client, if we think the client is telling us factual information now, we want to include the client stated. So when you're documenting, you want your documentation to reflect what they state. So you might want to make sure that you're saying the client stated or using the quotation marks. And then you want to document what you observe. Okay, so unprofessional conduct, negligence. I think we have a couple more slides on negligence. The nurse does not do what is reasonable, what a reasonable, prudent nurse would do in a similar situation. So then you're deemed negligent. So what does that mean? So for example, a complaint gets to the Board of Nursing or that facility that you're working in, the patient or the family member, they complain. So they're going to go back and look at the standards of care, the Nurse Practice Act. And say, for instance, they line up 10 nurses and they give them this scenario and ask them how would they respond. They look at those responses and what we documented that actually happened and see, was it reasonable and how many of those nurses would have responded in the same way? Because we would have set the situation up so that it was pretty much similar, as close as you can get to what actually happened. A lot of times this comes up when there are emergencies. So if you're that person who's going to be working in that emergency room, you want to make sure that you're well trained. Even after you get through orientation, if you decide, hey, I need more orientation because I'm not familiar with this process, this procedure, you need to speak up for yourself. I understand my orientation is over, but I need to extend because, if things move so fast in those settings. And so not to say that you can't have, unstable clients in any setting, but we know the emergency room, things pretty much come in, they're unpredictable. And so, if you're in a situation, you say, well, hey, I just, it was so crazy that day on shift. I did this and did that. I just did the best I could. So they're gonna line up. They're gonna look at the Nurse Practice Act, the policy procedures, and they're gonna ask other nurses, expert nurse. They get this information. Well, what would you have done? And if things pretty much match, they say, hey, this nurse didn't do this nurse is not negligent. They didn't do. They did the same thing that another nurse would have done in that similar situation. Um, if you're going out to, if you're going to be like that public nurse where you're going out to disaster scenes and things like that, you want to make sure that you get that extra training, well, just the training specifically, and make sure you understand, because they're all while they have all these scenarios, sometimes you just can't come up with the scenario. So just make sure you have that strong foundation and understanding of what you need to do. Even if what you need to do is reach out to someone to ask what to do. So don't be afraid of that. So violation of nurse practice acts, such as becoming personally involved with the client. Incompetence, examples include failure to meet general accepted standards of nursing practice. A nurse's mental disability that would interfere with the client's safety. Unethical conduct includes breach of a nurse-client confidentiality, refusals to provide nursing care for someone because of race, creed, color, national origin, disease, or sexual orientation, violations of the ethical code for LPNs, and failure to maintaining nursing competence. Alcohol and other drug use. If this client, are you a threat to this client's safety? Are you a threat to your colleague's safety? This is real, you all. Even though we're that trusted, the most trusted profession, some nurses steal. They sell. Patients are on all different kind of medicines. So, it's it's bad that we have to put this up here, but we want to keep it real. So, things might happen. So just make sure that you're following that policies and procedure. If it says you need a second, if you need a witness, if you are the witness, make sure that you're seeing whatever it is that you're witnessing. And, if the person says, well, hey, I already did whatever. No, I can't witness it because I didn't see, what I'm witnessing. So, and what I'm talking about is, for example, if the nurse needs I know some facilities require a second nurse or witness for insulin administration, for some pain medication. If you have to waste medications, for example, if the client has an order for 150 milligrams, but the medicine comes in 200 milligrams. So 50 milligrams of that has to be wasted, whether or not that's a cc or half a cc. You have to have that second person, that witness, to say, hey, yes, we actually flushed this down the dumpster or the waste disposal system. If you're signing off on that second witness, make sure that you are witnessing whatever it is, because you don't want it to come back where they go in and ask those clients, those patients, hey, and then the next nurse will come on and they're saying, hey, I need something for pain. You got in report, when you were doing, using the S-bar, and they was giving you report because they were going home, you were coming on. This patient got pain medicine 30 minutes ago. Well, yeah, it takes a while for that medicine to start to work, take effect. But then you go in and say, hey, it's my understanding you got medications, an hour ago, or whatever it is. And the client says, hey, I didn't see my nurse since breakfast when I got my morning medications. Hopefully that client is, I don't know. But anyway, so you're running into all different kind of situations. So keep in mind that colleague reporting, hopefully you don't have to do that, but sometimes things happen because, somebody might decide to steal, or, they take the client's medication and say they're giving it, and also they're not using it, disposing of it properly. Those are two things that come to mind. They're saying they're administering that medication and the client hadn't seen them or their meds, and then that disposal. So just make sure. So disciplinary responsibility of the board and unprofessional conduct. Okay. So the client, depends on what's going on, the board will decide, what's the next steps. Will they take your license? Will they just put them on suspension? And with that, a lot of times they have these programs and, steps that you have to do in order to, regain those license. And then once you come back, they'll also maybe have the nurse to work in a monitored type situation where maybe that nurse can only work if there's, the DON is in the building or RN is in the building. But they do have programs in steps out there to just not strip the nurse of their license. But if a nurse has a problem, they do have programs to prevent, to hopefully be proactive and get that nurse help before something happens that we can't undo. So a nurse is reported for stealing a client's narcotics to the State Board of Nursing. After receiving a complaint and determining that a chemical has affected the nurse's judgment, rendering them unsafe to practice, and confirming that the stolen narcotics are a violation of the Nurse Practice Act and the law, the board will review the complaint. They're going to review the complaint. The board will investigate, including questioning the witnesses, and they're going to gather evidence. So if a facilities, make sure we're abiding by that facility's policies and procedures. And it could be something as, we think it's simple, but if like coming into a facility, if people are supposed to log in, whether that is in writing or, like a lot of places have it where you have to put your name in a computer or write it down on a log. We want to make sure people are following that facility's policies and procedures, because someone can make up something and it can go back to that law. But they said 10 people came in and took all mom's stuff and ran out of the building. 10 people came at 4 p.m. on, what is this, April 14th. So when the board is going back and gathering evidence, they're going to investigate and they're going to question witnesses. Did you clock right? Did you clock in and out? Whatever that procedure is for clocking in and out. If that time clock has problems, you need to be writing out of whatever that complaint thing is, or what do they call it? A maintenance log. They call it different things, but you're writing down, this clock did not allow me to clock in and out correctly. If people came in this facility and they refused to do the sign in and sign out procedure, we want to make note of it, that this happened. Because in the midst of the board, remember we have the complaint that the family member said that 10 people came in at 4 p.m. on April 14th, went into their loved one's room and gathered up all their clothes and their TV, took their TV. They're going, gathering evidence. They're going to see who was on shift. They're going to look at that time. They're going to look at the, so how do they know who's on shift? They're going to look at that clock, who clocked in and out. You might have even been at work that day, but then they called your name because they just remembered your name from somewhere. So that's going to verify whether or not you were even there. The visitors log, because we got people to sign in and out like they're supposed to. We see at 4 o'clock, no one came to visit. Most facilities have cameras. Those cameras do work. If you look on the front door, they had a little sign that says, "Hey, you're on camera." They're going to roll that camera back. They look at 4 o'clock, the 14th, the 13th. They went to the 15th, the 16th. They didn't see anybody come in at that time. So that's all part of gathering that evidence. So, and it could be the opposite. At 4 o'clock, 10 people really did come in and one person left out with a TV in their hand. So anyway, so just, I said all to say, whatever those facilities, policies, and procedures are, try your follow them, because they're there to really protect you and that client and that patient. Because we, as you all mentioned early on, people do tell things that are not true. So the nurse will have the opportunity, the nurse is given the opportunity to respond to the allegations. And so right now it's only the allegation during the board proceedings. The board action follows the board proceedings in which the disciplinary action is determined, and then reporting and enforcement. The other side, well, hey, we're going to dismiss, or we do find that this nurse is liable, and then these are the next steps. And so we do have these huge databases called Nurses and National Practitioner Data Bank. And so in the nurses system, the nurse's license is there, the license number, the date that license expired, and any violations. So they don't tell like your date of birth, it doesn't tell where you live, what your bank account number is, what your, Zelle number is, any of that stuff. It just says, hey, this is a nurse, their license here, and this is their license number, and this is when their license expired. So, but before this data bank, you have to submit it to like this data bank. All the states are in, every nurse is in this data bank. So when you go to work for a place, they have to verify that you have license. Now, you all don't ask that question about, well, how do all these nurses work that really didn't have license? I'm not sure how that really has happened. And I saw it in the news not too long ago where they said a nurse was working without license. I don't know, but the facilities are supposed to verify, and they have this nurses data bank that they subscribe to them, and they're supposed to be able to look around in it and see if they see Daffy Duck nurse working in New York, the license number is this, and this is the date it expires, and see whether or not they have any violations. That's what's supposed to happen. And if they look in and they don't see that Daffy Duck has a license in that state, then they should not employ that person to work as a nurse. So then they have this National Practitioner Data Bank. I just think it was a huge file cabinet. It keeps all this information. And what this one is, anyone that has been reported or have any disciplinary actions, they keep all of their information in this data bank. Because before this data bank was created, a person could have adverse actions and disciplinary actions, and the next state over, they wouldn't know it. Or even within that state, when they went to that new place to work, that place wouldn't know it, other than that person telling them. But now facilities are required to report. Nursing boards are required to put that information in there, just so that people are aware when this happened, it's been resolved, just so they'll know. Or this happened and they don't have a license. Their license will revoke, so they cannot go on and work and be an imposter. So State Board on Nursing, they have a online verification. And like I said, it doesn't tell, but just the minimal information that's needed. So you all are able to, I'm not sure what the procedure is for you all, but for the most part, in most states, you can get that temporary permit. Some states, I know back when COVID was still huge, if you, they extended the time that you could have the permit, because before it was like 4 weeks or 6 weeks, but I want to say it's much longer than that now. And you all may have even started some of those conversations with your campus deans, because that's an option that you can have before you sit for that NCLEX. You can subscribe and get those temporary license. If your state is in a nursing licensure compact, what that means is several states have decided, hey, they've decided this is what we want. And if a nurse decides, because you can have a single state or the compact license. And you don't have to be part of the compact. You can also have a single license in each state as well. But if you subscribe to the compact license, whatever states are in that compact, that means you can take that license and work in those states. But if that state is not part of that compact, you cannot. You will need that single license for that state. Okay. So nursing standards of care guidelines for good nursing care, important legal implications based on what an ordinary prudent nurse, not the super nurse, just a regular nurse, which, everyone's a regular nurse, what would they do based on that? And they compare even the education, the settings. They would not take a nurse, like if something happened with this, there's a complaint, and this nurse was a LPN. They're not going to ask nurses that were advanced practice nurses that worked in NICU, what would they have done? That's not similar. Those are not similar education experiences. Those are not similar nursing experiences. So it's going to be, apples and apples. Well, if the complaint is against this nurse that has worked in a long-term care facility for 5 years, the nurses that they're asking is going to be nurses that's worked in a long-term care facility for maybe a range of 5 to 6 years, or 5 to 7 years, or 4 to 7. It should be as closest to apples as it could be, because otherwise it's not similar. And then what those nurses might say might actually indicate that this nurse did something wrong. But no, what you're talking about is your experience as an advanced practice nurse working in ICU, working in OB. And the complaint is about a nurse that worked in med surge and they've been there for 2 years. So they try to make it as fair as possible. So, but know that there can be criminal and civil. So with criminal, government versus the individual. Felony, it could be a felony, a misdemeanor. And so this is where if they deem it was homicide, those things are not standing, and we administer the medication anyways, and this client actually dies, and they trace it back and say, well, that medicine that we gave them on April 14th at 4 p.m. is a direct cause. So, like I said, they do have these procedures in place. Let's try to abide by them. So, civil is individual versus the individual. A lot of times there's a monetary compensation for, that. So, intentional versus unintentional. So, intentional torts, this is where someone intended to actually hurt, cause harm. False imprisonment and use of restraints. So, if, patient in room 201, they are disruptive and, they make, I don't know, they interrupt. So they're hollering out, just some different examples. So what we do is patient in 201, we close their door. So while, the activities is happening, we close them up in their room and we know they cannot open that door and get out. But we're closing the door because, they're being disruptive or the sounds that they're making is interrupting. That's false imprisonment. It's like, well, we just closed the door. Well, what interventions? Why is this client hollering out? Why is this client disruptive? Is it a behavior? And if it's a behavior, what are the next steps? Do this person need to be on a behavior unit? Do they need to be assessed in a different facility? Because they do have facilities that, manage disruptive behaviors and things like that. And so even with the use of restraints, in a lot of states, if they're in long-term care facilities, you don't see bed rails. Because remember, long-term care facilities are supposed to mirror your home-like environment. While some people do have those hospital beds inside of their homes, for the most part, there aren't hospital beds. And then our beds don't have rails on them. Some states have even tried to justify it and says, well, hey, the person was using the rails to reposition themselves. You can grab the rail and you really can. But whoever wrote up the legislation and passed the bill or whatever, they were saying that even was a restraint, because can that person reach and let that rail down on their own? Or does that rail require someone from the outside walking into that room, adjusting whatever thing on that button or whatever, and let that rail down? So that person really is restrained in that bed inside of those bed rails. And a lot of times, most hospital settings, you usually don't see all 4 rails up. You see like those at least one half of that rail will be down for the most part, unless that client, they have a whole different policy and procedure in acute care settings about restraints. There have been some great, what do you call those things? What's the word I'm looking for? People have designed and created like all these things, but what we found out is they really were restraints. So you all know like the little baby chair that they, we put them in, and they have like the little tray. They're learning to walk, they're learning to move their legs around, and they're moving around. Those little things. Someone designed one of those for an adult. That is considered a restraint, because if you think about it, unless your baby have outgrown, pretty much can move their legs pretty good, they pushing and pulling, they really don't need to be in that thing. They will try to climb out, but otherwise they can't get out of those things. So someone designed, and I forget what they call those chairs. There's a chair, but essentially it's like that. But once you put the little tray across them, they can't release that tray. So essentially it's a restraint. So facilities have to stop using those. And going back to the bed rails, the data showed that people were getting broken arms. They even show people had neck injuries from people pulling up the bed rails because they did not clear or make sure that the bed, before they pulled that rail up or let that rail down, that person's arm and neck and everything was out of way. It's like, what in the world? who would have thought all of that? But so that was a supportive data for them saying that bed rails should not be used. But some facilities, you still see them there, and they've written up whatever it is that they've written up to justify why they're there. So unintentional toys, it's unintended, but still this person had some type of harm that came to them. The nurse did not go out of their way to intend to, cause harm to that client, but it's still a thing, unintentional tort. So some common sources of malpractice, you all: medication errors, taking the time to make sure that order is correct, making sure your medications are matching, making sure we go in and we're using those identifiers. In addition to the person saying their name and date of birth, some facilities have pictures, they have names. The hospital says we have armbands, but we want to verify that this is the correct person because we don't want to administer the wrong medications to them. Working while impaired, and impaired could be substance, or it could be that you're just too tired. You went on a trip, as soon as you got back from the trip, you were scheduled to work. But once you got there, something happened, and we can relate it back to the nurse being impaired. They were sleepy, because if you're sleepy, just think about people driving on the road and they're sleepy. What happens to them? They usually run off the road. Sometimes they have accidents. So even if we're too tired, for sure, if you're using substances, please don't work impaired. It'll be like a call in or a point on your thing, but we rather that nurse call in and no harm come to them or the clients. If they are just not fit, even if you're sick, you're not feeling well. I know they had this thing during COVID. You could cohort, like if the person had COVID, you could take care of people that had COVID. But if that person was just too sick to pick their feet up and walk, they didn't need to be in there, even if they did have COVID. They didn't need to be in there providing care to anyone. Failure to follow those standards of care. We talked about that Nurse State Practice Act. Lack of observation and timely reporting about the client. We talked about assessing, interpreting. We're looking at our client. We are looking at their lab values. They've called the lab values into us. We just put the information on the chart. Based on our observation, we probably need to call the healthcare provider and report this, but we just document. That is lack of timely reporting. And as a result of it, more than likely harm is going to come to that client. Failure to use a medical device accurately. There are all different kind of devices out there. If you've seen one, you've seen them all. No, that is not true. So if you're working in facilities and people bring in or have these devices, you want to make sure that you're trained on what to do, how to use this device. Failure to communicate. That's that, we're not calling the healthcare provider to report. Failure to properly supervise a client. Negligent delegation. We want to make sure that in supervision, even though we delegate a task to the unlicensed personnel, does that mean that, we're done with that task? Or should we come back and supervise and ensure that task is completed correctly? When we delegate, my question to you, and you can come off mute and say yes or no. When we delegate a task, does that mean that we're done with that task? Or should we come back? That's right. Even though we delegated, we had delegated appropriately, we make sure
You
that
still have to make sure that it's properly executed.
exactly. You gotta go back and supervise. So if a client tells you, hey, that doctor came in or that dietitian came in, I didn't know what they was talking about. And now they want me to make a decision. So we have to advocate for that client to say, hey, this patient didn't understand what you were saying. Would you come back in and explain again? They don't want to consent. I know they signed up on that consent, but they're telling me that they just signed off on it because they thought that was the better thing to do, but they really don't understand. That person can change their mind, right? They could be on the elevator going to wherever, to the surgical room or whatever. That client can change their mind. But if they are saying, hey, I really didn't understand, or whatever they said, I need more information because I want to see if there's an alternative, we have to advocate and call and say, hey, client wants to select other food items. Client wants to change their mind about the surgery that they're going to have in an hour. They want to, talk with you about alternatives. And so, of course, failure to get informed consent. If we don't have consent, we shouldn't be moving forward with procedure. So let me stop and ask some questions real quick. So is it legally, ethically wrong, or right? Go back to that, and that helps us to determine what are our next steps. Let's see. What if our clients do want life-saving measures taken, and they changed their mind? Initially, they said they did not want life-saving measures, but now they say, "Hey, nurse, I've changed my mind. I want everything done." What should that nurse do?
Get the proper documentation signed.
What should happen before then?
When you call the healthcare provider,
Call the healthcare provider, notify them that, hey, their wishes have changed, and what they're going, the next steps after that is going to be, well, hey, we need something in writing, and they're going to get it all written out, and that client's going to say off on it. And so, yes, notifying the healthcare provider, hey, they changed their mind. It could be either way. I do want life-saving measures now, or I changed my mind. Don't do anything. I want to be a DNR. Either way it goes, we're going to notify that healthcare provider that those clients' wishes have changed. And then the next step will be more than likely getting that documentation. So making sure that we do understand that non-malfeasance is do no harm. Go back to that slide. Beneficence is to do good. Autonomy is free to choose. Fidelity is to be true. And then justice for all. Let me find that slide right here. So just make sure and understanding these concepts. If you get a scenario, we just go thing out the way. If you get a scenario, then you'll be able to answer. So make sure non-malfeasance, make sure you have that, do no harm. Beneficence, do good. Autonomy, free to choose. Fidelity, be true. And then justice, fair to all. Okay. See if I can give you another little scenario here. So when we say do no harm, let me just create an example. Okay, so doing no harm, because that's one that non-malfeasance. That's a big one. So when we're, for example, if we are going in to insert a Foley catheter and we break sterility, it's an honor system. Your instructor is not going to be there. What are we supposed to do if we break sterility? Should we just go on and put the Foley catheter in anyways, or should we
get a new
start
one.
all over? Okay.
Start over.
What if we're supposed to set up a suction? We get the suction machine, we get the tubing, we just place it in the room. We don't actually connect the tubings. We don't have it. We don't even plug up the machine. Now the tubing, sometimes people, you might just have it there, but at least it's plugged up. So if we're setting up suctioning and the suction machine is not even plugged into an outlet, and we come in to use it, for example, if it's critical situation, we are wasting trying to find where is an outlet. We go to turn the machine on. We have the equipment there. We can't even turn it on. We can't even use the suction. So we're having to use up time to find an outlet. Is that causing harm? Could that potentially? Okay.
Just like time is the essence. It's of the essence. So like you have to have everything ready to go because that could cost someone's life.
Exactly. So if we go in and we're setting up an oxygen flow meter, we're setting up a constant oxygen concentrator, we're setting up suctioning, and you don't see a few pieces of the equipment that's needed, we got to get those pieces. We want to make sure things are plugged up. We want to make sure that tubing, if it's supposed to be connected, we want to make sure that it is actually connected. And it seems like something's minimal, but it really is that's a biggie. It's like, well, I just put it right. They had everything they needed. Well, we needed, it took us 5 minutes or 3 minutes or whatever to set everything up. And so that took away from, they're gonna line those nurses up and say, well, hey, if you would have been the person to go in and set up the oxygen concentrator or the oxygen from the wall or the suction, what would you have done? Tell us what steps would you have taken? So we talked about the Nurse Practice Act, but the American Nurses Association Code of Ethics for Nurses, they set the standards of conduct and behaviors for nurses. And then the Nurse Practice Act guides those nursing practices in each state. So you have the ANA. So that's like the overarching, that's like at the top. Like if we were to line things up, we have the American Nurses Association. And then from that, each state creates their Nurse Practice Act and they pull those things. Yeah, it's similar things, but in some states, and states have to decide whether or not it's lawful in that state for the nurse to do that. If it is, they pull that information from the American Nurses Association Code of Ethics and they put it in their Nurse State Practice Act. But if one state is illegal for a nurse to do something, so while it's listed in the American Nurses Association Code of Ethics, that state cannot pull that to their Nurse Practice Act. Then they would be practicing unlawfully because in that state, you can't do that in that state. And I can't think of right now intervention that would be like that. But some states, their laws just vary. And so an example still just doesn't come to mind. But essentially, if you know that if it's not in your Nurse State Practice Act, then you can't do it in that state. But it comes from that American Nurses Association Code of Ethics. That's where that comes from. I think we did, let me see. What's another good example? Let's see here. Like I said, for the most part, you're going to have to be able to know what the term is in order to apply to a situation. So we talked about fidelity, just being true. If making sure that we follow, that we're acting in that client's best interest. We're not getting their debit card or, getting their checkbook, to go and purchase things for ourselves. Even for them, if they're in these facilities, see what that facility's policies is about this person spending their own money, because we want to make sure, because we don't want this client to get confused later on and say, hey, I didn't tell that nurse that they could take a picture or they can take my checkbook and go to town and go purchase me something down in the gift shop. So we want to make sure, and I know like for this group project, you're going to use different modes of communicating, text messaging, WhatsApp, all those different things out there. Don't do that if you're working, in taking care of patients. So inappropriate information that's shared, whether it's a picture, because a lot of facilities take pictures of wounds and things now. Making sure that we're using, if facilities have devices that belong to that facility, making sure that those pictures are only on those devices, making sure they're not on our personal devices, because that will breach the ethical principle of fidelity. It's time for our next break. So you all, let's stop and take another 5-minute break. Let's see, return at 7:37. Then we'll finish up our content and then we'll get in our groups. Turn your cameras off, but remember this recording still plays. Okay, so what we're going to do is use some time to get into our group 10 our group week 10 groups. Now, mind you, you need while you're in that group, look at that rubric and begin to discuss what your PowerPoint will look like. What things are you going to say? Remember, there is a time component to that. I think it's 5 or 7 minutes. So while we want all of our points, just make sure that you start discussing that. Look at the rubric, go ahead and exchange and come up with ways that you all can quickly get in touch with each other, whether or not that's Outlook, Canvas mail, have more than one way of contacting each other, whether or not that's group text message, whatever you all decide. Know that you cannot complete this project during class time. It is going to require you to meet beyond class time. So it's week 10. Seems like a long way away, you all. But remember, you have work, family, all of these responsibilities, and you want to present your best work. So while it is a way off, don't procrastinate, because remember we said procrastination was not our friend. So go ahead, start early on, because even some way halfway through the project, sometimes you as a group will come to a consensus and say, hey, we need to redo our game plan. And so if you figure out that, early on, then you have enough time. And then once you get to week 10, you're able to still present your best product. So I am going to upload the document, and also I'm going to send it out to let me put it in the announcement section first. And then we'll use some time while you all are in your groups discussing, exchanging information. Remember, let's be we don't want to be, what is that thing? Remember the different leadership styles: democratic, autocratic, laissez-faire. Want to discuss, real things and solutions. We want to come to a consensus where we might not all agree up on the same thing, but let's, agree to disagree to come up with whatever's going to be best for the group. Now, if you were doing this individually and working by yourself, you would do it, one step, two step, or however it goes, but you're working in a group. And so consider that as you're deciding, what you're going to do. So I'm putting it in the announcement section here. The next piece is I got to put y'all in these groups. So give me just a moment to put you in the breakout rooms. And while you in there, I did have a few more things to cover. So we're recording. So I'll go ahead and finish recording that information. So when you play this recording back, you will have the rest of that information on there. So let me just put you all in your groups real quick here. Let me pull it up. And then some, email is good, you all. But you'll come up with your way to, let me minimize this. I'm trying to get both of these things on the screen at the same time. Okay. If someone needs to contact you pretty quickly, what's our rule for our guidance for doing that? Okay, I'm opening up the breakout rooms. Your topic and your groups are posted in the announcement section. Then go to week 10 to look at that rubric. So we'll give you all some time to look at that, and then we'll bring you all back, and then that'll be the end of class. But meanwhile, I will be reviewing the last few concepts here while you all are in there discussing planning. as you can execute correctly and give us your best product on week 10. So accept the invitation to the breakout room and just look in the announcement section just to make sure I put you out. I think everyone in a breakout room. So go ahead, go to your groups. Okay, which statements best defines ethics in the context of nursing practice? Ethics is a study or examination of morality through various approaches. Okay, so non-malfeasance requires a nurse to avoid causing harm to the patient. Is what I'm going to do, is this task, is this intervention, is going to cause me to avoid? You want to ask yourself that question when we're talking about non-malfeasance, okay? The Code of Ethics for nurses established clear priorities such as compassion, respect, advocacy for those patient rights. Our patients, they might not have the same values. They may not agree with what your personal values and things are. They may not match up, but we want to respect and provide that best care for that client and that patient. We do want to make sure they have enough information to make an informed decision. And if they refuse, then we respect that. Applied ethics refers to the process of approaching daily life situations with ethical theory and reasoning to daily life situations. Justice in nursing ethics means treating patients equally and fairly. No matter what their pay status is, they may have insurance. They might not have insurance. They might have insurance and it's not enough. This person might be a frequent flyer. They may have repeated admissions to the hospital. It does not matter. We treat every client equitable and fair. This client may be a non-compliant hypertensive patient. This client may be non-compliant diabetic patient. This patient may be an alcoholic, substance abuser. We still provide the equal and fair care to our clients. Bioethics deals broadly with ethical questions surrounding biological sciences, healthcare technologies, and health policy. So, nursing education, family and peers, and workplace. These are common influences that we have to deal with when we're talking about ethical practice in nursing. It says, which factors commonly influence the development of ethical practice in nursing? So that's our education, our family and peers, and the workplaces. So here it is. We have a patient asked a nurse if the medications they are receiving has any side effects. What is the nurse's best response in relationship to the ethical principle of veracity? Okay. And so we don't want to tell them, oh no, this medication doesn't have any. We want to be truthful to this client. Yes, it does have side effects. And we can let them know what some of the common ones are. And also we can get patients can have those printouts. But we don't want to say no, or you don't know, or don't worry about it, you'll be fine. Yes, it does. And we can let you know what the most common side, or we can get you the list. That's why we're with the pharmacies, they just print out those when you get medicines refilled, they just give you those handouts, so that you can always refer back to. Because right then you might not have any questions, but once you get home, you might have questions. So you can pull out those handouts and actually refer back to those. A nurse should report any observed behaviors that are potentially harmful to the client and also to the staff. We need to report that if it's potentially harmful. because we want to be proactive. In the event that there's a misunderstanding, miscommunication, or something that counts confused, they may have a traumatic brain injury and they may be hearing things or seeing things that are not there. If there's going to be a potential harm to the client and the nurse, we want to report that. We talked about beneficent paternalism is actually the opposite of autonomy. Is used for emergency situations. It is where there is just the client's input is just disregarded. It is not even considered. The client or the patient or the patient's representative have made a decision. I want this treatment or I don't want this treatment. And with beneficent paternalism, the healthcare provider comes in and say, hey, I think you've made the wrong decision. So the courts are petitioned. This is usually say for emergency situations. It's not anything that you routinely see. Ethics committees assist with difficult ethical decisions in healthcare settings. And this could be an additional task that you might be asked to when you go to work at your different facilities in the different settings. They always have an ethics committee. So you might be asked to work on that committee. And the whole purpose of it is, receiving these ethical issues and then seeing if, the facilities following the appropriate policies and procedures, or staff following their Nurse Practice Act. Did the right thing happen? Do we need to revise our policies and procedures? And so just know that facilities do have those committees to work through those ethical issues. Critical thinking helps nurses sort out ethical choices and legal responsibilities regarding client care. That critical thinking, we can't get away from that critical thinking and the nursing process. Fidelity means being faithful to the client's best interest in maintaining that trust. Okay, being faithful. We're saying that we're coming back, or I'll be back in an hour, or I'm going to bring your water pitcher right back, or I'll be writing with your pain medications, making sure that we're doing that. And in the event that we cannot, then we communicate with that patient, that client in some type of way and let them know, hey, there's a delay, or I'm going to ask, someone else is going to perform whatever it is, the activities for them. Nursing ethics include principles such as non-malfeasance, beneficence, autonomy, fidelity, and justice. So the United States Department of Health and Human Services is a federal agency responsible for administering health programs and also those regulations. Okay. Medical malpractice lawsuits require proof of duty of care, breach of duty, causation, and injury. So in malpractice, they will look at, well, hey, was this nurse assigned to this patient? What did the care plan say that the interventions were to be carried out for this client? What did it say that this client needed 2 persons assist when walking and ambulating? That this person needs 2 persons assistance with turning and repositioning? What was documented? Was it just 1 person in the room? And then if the person ends up with the injury, is that injury directly related to that nurse not following what that care plan said, which equals to a breach of duty? But if the nurse acted in the way and followed that care plan and that client ended up with the injury, then there won't be any relation there. Then there's no medical malpractice. But so be careful when you're getting assignments. If you're exchanging patients, making sure that things are exchanged correctly, because you don't want something to come back up and it looks like you were the one that was supposed to be taking care of this client and you breached your duty, when in actuality, you were not assigned that client. You were not assigned to take care of that client. The anti-kickback statute criminalizes incentives for patient referrals in healthcare. So it's saying that, a kickback, well, I get a kickback for, or that healthcare facility or that company gets a kickback for referrals. So then, well, why is that facility always referring clients to just that facility when there are 10 in town? Well, it could be that that's just the facility of the patient's preference. But if they find out that referring facility is getting money or some type of kickback or favoritism because they're referring and sending all those clients to that particular healthcare facility, then that's criminal. They can be brought up on criminal charges. So HIPAA sets federal standards for protecting patients' health information and their confidentiality. So we want to make sure that when we're discarding even the packages that medications come in, we want to make sure that we obscure or get rid of any identifying information that's on there. What is the facility's procedure for discarding, records and anything with identifying information on it? We want to make sure we're following that. Advanced directives allow patients to specify their healthcare preferences and appoint agents for decision making. Vicarious liability holds employers responsible for employees' negligent acts within the scope of employment. So a lot of times when people sue, they look and see, well, can they sue the nurse or should they sue the facility? And so usually the liability holds with the employer. So, but that does not negate the fact that you as a nurse need your own insurance as well. A tort law provides relief to harmed parties, imposes liability, and deters wrongful acts in healthcare. That's that tort law. Malpractice is professional negligence resulting in harm to a client. We just talked about those pieces that must be there. What was I assigned this client? That's duty. Did I not perform or take care of this client according to that care plan? And if that client had an injury, is it directly related to that nurse not performing or completing that task as outlined? Did this client really give us informed consent? So informed consent requires that the client understands the procedure, the risks, the benefits, and if there's an alternative. The example that I gave earlier, the client signed off on to have the procedure. Then when you came in the room, because you've established that therapeutic relationship, they say, hey, I just signed off on because the doctor was standing there looking at me, but I really want to know if there's another option. So it's on us to go out and notify that healthcare provider, hey, this client, what they said, and they want to know if there's an alternative. And that healthcare provider comes back in and let that client informs them of what the alternatives are. So a living will is a legal document specifying desired medical treatments if a person is terminally ill.
I have a question. Are we doing a poster or a PowerPoint?
PowerPoint.
Okay, PowerPoint.
Mm-hmm.
Okay, cool.
So everybody should be coming back. Should be back in about 30 seconds. And so there is not a slide count. But of course, you always have your your introductory slide and then your reference slide. But there is not a slide count, but there is a time. So just make sure that, whatever it is you all decide, that you are talking to us, because you don't want to lose any points because, it says you're supposed to talk 2 minutes and you only talk 30 seconds. And so look at that rubric, make sure you're aligned with that rubric, but it's a PowerPoint.
So I was gonna ask, because the rubric that we see like on week 10, it's for a poster.
Mm-hmm.
Do we follow the same thing?
It's a PowerPoint. That is correct.
So a PowerPoint. Can we pick more than one topics to write on? Or we just got to pick one topic?
You've been given the topic. Look in your announcement section.
No, we see it, but we trying to procrastinate about some stuff. That's what I'm talking about.
Yeah, you all go back
You
and
mean
forth
confused?
and flesh
I'm
that
just
out.
trying to figure out exactly because we got navigating ethics, but navigating ethics is that
What
you want
is
it
that?
broken down into the whole, or
That's what you're gonna do. You're gonna break those are broad topics. You're right. You're gonna break it down. What are those pieces that's gonna once we finish?
so like legal and ethical principles.
All of those
Got you. Okay.
Yeah.
I just
better not
wanted
give
to
us
make
no
sure that
point
I'm
off.
comprehending this right
We gonna
because
throw
at first
everything we have at you.
I was like, hey, no way, this little 2.5 sentences is gonna confuse me.
I'm
It's
good.
going to be more information. You're going to have to narrow it down. The
Okay, got you.
time component, if you flesh it out, take all the moving parts, you're going to meet that time component. You're going to talk more than what you really want to. So, but yes, so it's broad, but they're all different little pieces that make up that broad topic. Okay. And so I do owe you all, because we're over. You supposed to 4 minutes ago. So remind me 4 minutes of next week. We got to add 4 minutes. So I want to be good stewards of your time. I still have 4 more slides to cover. You all are free to go to take our last break, but I'll stay on to finish going over those last 4 slides. Once this recording is downloaded and uploaded, I'll share the link. Make sure you go back through the classroom recordings and the exam reviews. Exam 1 is next week. Take care, and we'll see you then.
All right, thank you.
You're
You
welcome.
have a good one.
You too. A living will is a legal document specifying desired medical treatments if the person is terminally ill. So this living will, it is binding. The example that I gave earlier, for example, the person, they have decided do not resuscitate. They don't want to be intubated. And we just know in our hearts that, or our minds, that doing those chest compressions will bring that person back. In the event that we do those chest compressions and this person has a living will, then we're in trouble because we have acted against this person's wishes. So just mind you that those are documents in these person's charts, and they have on them, these are legal documents. In regards of how we feel personally, we have to abide by those. So a living will and a power of attorney, are they duplicate documents? No, they're not the same. One specifies a person to make decisions, and the other one, it has a document that says, hey, I want this treatment or I don't want this treatment. So the Good Samaritan Act provides immunity from civil liability for emergency care given in good faith. We're riding down the road and we see a person, they've had an accident. We stop to render aid. That person tries to sue and say, hey, this person, when they stop to help me, they're the reason why, whatever. And so that Good Samaritan Act protects that healthcare provider because you stopped to render aid in good faith. You did not stop to help them, to cause them harm. So that act is out there. False imprisonment occurs when a client is detained against their will without justification. It seems like simple, just closing a door or putting a person in a room, in a room they can't get out. They don't have free egress. They can't get out. Then we're imprisoning that person. A do not resuscitate order is a legal directive to withhold CPR or advanced life support. Nurses must report suspected abuse according to the facility policy and state law. We are mandated reporters. Do we have to know all the details? No, we don't. If you suspect it, we must report it. It's on someone else's responsibility list to go in and gather the information to do the investigation. But we are mandated reporters. If we suspect it, we must report it. Personal liability, and usually they don't ask your name when you call in to report those things. So don't be afraid to report, because even if there's not anything going on, there's not going to be anything going on. It's not like it's going to be announced on the news, hey, nurse, whoever reported the people that live on Apple Street, they are, suspected of abuse. We're not going to do, that's not going to happen. But, and so in the event that nothing is really going on, it's going to come out that nothing's really going on. But if we suspect it, we must report it. Personal liability means a nurse is responsible for their own actions and decisions. Right now, you're up under that preceptor or that mentor or that clinical instructor. You are doing your clinical rotations. You're under their license. But pretty soon you'll be out on your own. And it means that you're responsible for whatever actions and decisions that you make.
Alrighty.
I'm ending the recording, you all.